Hi, my name is April Ybarra. Today I will be presenting a webcast regarding anterior myocardial infarct and partial fulfillment of the requirements of N5308 nursing informatics. 1.5 million myocardial infarcts occur each year, with most of them occurring in a single coronary artery. 10% of those infarcts are in patients that are less than 40 years old. 45% of those occur in patients that are less than 65 years old. Of the patients that have a myocardial infarct, 50% are expected to perish within the first 60 minutes of onset, 30% within the first year, and then 3 to 4% for each year thereafter. Muscle damage extends throughout, and death of cardiac muscle is directly related to the vessels involved. Evidence of an acute MI can be found in the patient anywhere from 3 to 5 days of acute onset. It's been found in 95% of the cases of cardiac artery dissection that the cause is related to atherosclerotic plaque. Of those patients, 50 to 85% of the risk of coronary atherosclerosis is secondary to acquired conditions. Lipid metabolism, coagulation, and the renin and angiotensin-aldosterone system plays a key factor in this. MIs are common in the U.S. with 4 males to every 2 females in 1,000 population of hospitalized patients on an annual basis. As you can see by the diagram, cardiac disease development occurs in stages. In a normal patient, you would have a clear flow of blood circulation within the body. Once the atherosclerosis develops, plaque starts to line the inner lining of the vessels, eventually worsening to the point that you will have a complete narrowing and no longer have an ability for blood to flow in the circulatory system. An MI results in the death of the cardiac tissue greater than 1 centimeter when the muscle is denied oxygen related to the plaque obstruction. So as the disease worsens, the patient develops the MI because the blood can no longer carry oxygen to the muscle. You have 2 different types of MI. You have a non-reperfusion and a reperfusion. So in the non-reperfusion MI, blood flow cannot be reestablished via stenting or ballooning in the cardiac cath lab. You're successful when reperfusion or blood flow is reestablished after the cardiac cell death, which may be several hours. It's very important to look at a patient's risk factors and their genetic predispositions that could further put them at harm for development of cardiac disease. As previously discussed in the presentation, most common myocardial infarct locations occur in a single coronary artery. So therefore, it's very important to understand the anatomy of the heart. The right coronary artery, or the RCA, is where damage occurs to the posterior wall of the heart. The left coronary dominance, or the LCA, damage occurs to the posterior wall in about 15% of those patients affected. The left main artery, or the LMA, is the anterior lateral infarct, and the left anterior descending coronary, or the LAD, is where damage occurs to the anterior wall. Now, muscle damage would extend throughout that region, and death of the cardiac muscle again is directly related to the vessels involved. The goal is to reestablish blood circulation for reperfusion to stop the amount of damage that has occurred. In the patient that presents with an MI, you would expect to see signs and symptoms of chest pain, complaints of nausea, vomiting, diaphoresis, and often they will complain of pain that radiates to the neck, back, jaw, or arms. Presenting symptoms are different in males versus females. Males have the typical hand to the chest clutching, bent over. Women normally complain of epigastric discomfort and or an upset stomach. Also recall that in diabetic patients, they are usually asymptomatic, and that's found also in the elderly as well, in about 10 to 15% of those diagnosed. To confirm your diagnosis of an MI, you first would complete an EKG. You would either have a STEMI or a non-STEMI. So meaning you would have ST segment elevation in a STEMI or non-ST segment elevation in a non-STEMI. Cardiac catheterization is often performed for blockage confirmation. If you will refer to the diagram located here in the upper right of the slide, it gives you the basic description of how the stenting procedure and or ballooning procedure is performed. So they would actually do the PCI, the percutaneous balloon. They would go with the balloon deflated in the artery up past the level of blockage. They would then deflate the balloon and attempt to pull the blockage back and out of the vessel without any release of plaque, increasing risk of a stroke. If they're unable to remove the plaque with the balloon, then they can implant a stent in the same manner. Now, the stent is a mesh covered object that is deflated or flattened. It is fed up the artery past the area of blockage. Then the stent is inflated or opened, if you will. And what that does is it allows a reestablishment of blood flow through the vessel and pushes the plaque up against the lumen of the vessel, thereby trapping it from expanding and or trapping it from a potential dislodge of the plaque circulating through the body with the potential to cause a stroke in the patient. In addition to treating the patient with a trip to the cardiac cath lab for possible balloon or stenting for plaque control, patients are also put on oral medications. One of the most common are Plavix. Plavix actually reduces thrombotic events in patients with an MI. The action of the medication actually inhibits the binding of adenosine diphosphate to platelet receptors, impeding the ADP-mediated activation and subsequent platelet aggregation. It irreversibly modifies the platelet ADP receptor. Therefore, it doesn't allow the plaque to develop and stick, causing narrowing of the lumen of the vessel and the blockage. The peak of the medication is unknown. Duration usually is around 5 days. The onset is in about 2 hours. It's important to know that the half-life is 8 hours. In patients that have renal or hepatic impairment, you need to be a little concerned and be cautious in the way that you use the medication. It could actually increase bleeding from any trauma, surgery, or other pathologic conditions. In some patients, it may cause intracranial bleeding, hallucinations, hypotension, hemorrhage, bronchospasm, and has been found to cause Stevens-Johnson syndrome. You really also should be aware of potential angioedema development in the patient. You would monitor them for any signs and symptoms of bleeding, and then make sure that they're aware of patient education that they should not take aspirin. It actually interacts with aspirin, NSAIDs, warfarin, and macrolides. Nitroglycerin is another common medication that's used in the management of hypertension and heart failure after an MI. The action is that it reduces cardiac oxygen demand by decreasing left ventricular end diastolic pressure, which is preload, and to a lesser extent, systemic vascular resistance, which is afterload. Nitroglycerin also increases blood flow through the collateral coronary vessels, which tend to develop in patients who have a history of plaque development. Peak onset of the medication after IV administration is immediate. The duration is 3 to 5 minutes with a half-life of 1 to 4 minutes. As a nurse, it's very important to understand that nitroglycerin and medications used to treat erectile dysfunction do not like each other. So you must question your patient before you start the nitroglycerin as to their concurrent use of Cialis, Viagra, or Levitra. It's important also to note the last dose amount and time taken. If nitroglycerin is administered in a patient who has concurrent use of erectile dysfunction medications, it can actually cause a fatal decrease in blood pressure until cardiac arrest occurs. When you go to dose your patient, you would normally start your IV medication at 5 micrograms per minute, titrating every 3 to 5 minutes until relief of pain. It's important to note that nitroglycerin will cause a decrease in blood pressure on its own, so you would need to cycle the patient's pressure in between each titrated dose. Once you reach 20 micrograms per minute, if the patient's still having pain, at that point you may increase your dosing by 20 micrograms every 3 to 5 minutes until you reach a maximum dose of 100 micrograms per minute. When you provide patient education, make sure that they understand that nitroglycerin is a vasodilator, so that it can cause a headache, which you would request medication for should they begin to experience that type of pain from the medicine. It also has a side effect of dizziness, nausea, vomiting, and or rash. You want to monitor the patient's vital signs very closely during the administration of the nitroglycerin medication. In conclusion, acute myocardial infarction is considered a medical emergency where early treatment can literally be a lifesaver. The cardiac motto of an emergency room nurse is time is muscle. So every effort is made to get the patient to the cath lab so reperfusion of the occluded vessel can occur as fast as possible to provide the patient the best outcome. A level 1 STEMI facility provides the patient with the best chance of survival. These facilities are required to meet or beat the national benchmark of door-to-balloon time in 90 minutes or less. Reestablishment of blood flow provides oxygen delivery to the cardiac muscle, stopping cell death and loss of cardiac muscle function. I hope you've enjoyed the webcast and have learned a little more about the presentation, diagnosis, and treatment options of an anterior myocardial infarct. Are there any questions?